In order not to hold things up, we're going to move right into the testimony from the witnesses, and we will hear first from Dr. Balizet, who's an oncologist in a beautiful little town, I think we've been there once, from Pueblo, Colorado. Dr. Balizet.
Thank you.
Excuse me, just briefly, I'm General Siegel with Congressman Connors, and Mr. Connors wanted to announce that there will be a strategy meeting for those who are supporters of single-payer national health insurance, HR 676, and that'll be following this this briefing, and it's from like 4 to 5:30. There's going to be food here in case you're hungry. Mr. Connors wants to thank the Leadership Conference for Guaranteed Healthcare and PNHP and PDA. That's who is organizing this briefing today. Mr. Greg Smith from Europe, who says that the European system, you can stand up, correct? Okay. Says that the European system actually does work, unlike the people who say it's socialized medicine. But anyway, I hope that everyone can stick around for the strategy meeting, because it's going to be very important to talk about where do we go from here. Thank you very much.
Thank you. Thank you. Well, I'm a medical oncologist from Pueblo, Colorado, where I practiced since 1976. As do my two partners, and indeed the majority of American physicians, I favor single-payer universal health care. I'd like to share with you the stories of some patients I've cared for recently that illustrate why I believe that the current system is broken and unfixable. First patient is a lady who I'll refer to as Mrs. A, an 80-year-old woman with breast cancer. She takes Arimidex, a helpful but very expensive, to the tune of $12 a pill, medicine, in the hopes of preventing a recurrence of her disease, what we oncologists refer to as adjuvant therapy. When I saw her several weeks ago, she confided in me that when she reached the donut hole of her Medicare Part D coverage last year, she took her pills only every other day instead of every day, as prescribed. Arimidex taken daily is an effective deterrent against breast cancer. Arimidex taken every other day is a very uncertain value. Second patient, Mrs. B, 51-year-old woman who was discovered to have advanced metastatic colon cancer last year. Her treatment consisted of 3 chemotherapy drugs, one of which is given by a 48-hour intravenous infusion. This is usually accomplished in the outpatient department using a battery-powered portable infusion pump. Mrs. B was indigent and uninsured, as are many people in Pueblo. The only way she could get her treatment was to be admitted to the hospital, where she stayed for 2 days out of every 2 weeks. After 4 months, she finally got Medicaid, which paid for treatment in our office. Not only was the treatment in the hospital much more expensive to all of us in the final analysis, but it took precious time from her life that she could have much better spent with her family. Third patient, Mr. X, a 49-year-old married school teacher who was faced with pressing household expenses when it came time to sign up for continuation of his health insurance. He elected to forego health insurance to save his portion of the premium. He gambled that he would not get sick and require expensive health care, and he lost. He developed rectal bleeding, but put off seeking care, hoping that it was something benign. When he had bled enough to be unable to go to work, he was taken to the emergency room. Subsequent evaluation revealed a very advanced cancer of the colon. He spent a total of 3 of the next 12 months in the hospital. After chemotherapy and several surgeries, his cancer disappeared and he worked for several more years. Inevitably, however, because we can't cure advanced metastatic colon cancer, the cancer returned and he recently passed away. There's a relationship between insurance status and outcome from cancer, and incidentally from heart disease as well. Mr. X serves as an unfortunate illustration of this connection. Had he been insured, it's very likely he'd be alive today. In addition, the enormous, largely uncompensated hospital expenses could have been reduced immensely. Mr. Y is a 60-year-old man who developed lymphoma during a period when he was between jobs and uninsured. He responded initially to chemotherapy out of necessity in the hospital, but then relapsed. A bone marrow transplantation can be life-saving in this situation, but he now has insurance but with a 6-month exclusion on pre-existing conditions. We are hoping that stopgap chemotherapy can keep his lymphoma in check until his 6-month waiting period is over, but I am doubtful that this will happen. As long as we insist on a healthcare system based on private health insurance, we will have to accept the consequences of intermittent and patchy coverage. The consequences to Mr. Y may prove fatal. And finally, Mrs. Z is a 75-year-old woman who developed an aggressive breast cancer that had spread to her lymph nodes, serious but potentially curable by the successive application of surgery, chemotherapy, radiation therapy, and hormonal therapy, Arimidex. She made it through the first 3 treatments, but was stymied when she came to the 4th, since she could not afford the $300 a month copay required by her prescription drug plan. Help came from a mail-order Canadian pharmacy working in cooperation with local pharmacy service. She was able to get the medicine for 1/3 of that amount. Without this backdoor supply, she would have been unable to complete a crucial part of her treatment. Well, how do I envision life changing for me and my patients under single-payer universal health care? 1, approved oral drugs would be available for all. Our office staff would no longer spend hours begging, usually unsuccessfully, for free drugs from pharmaceutical companies. The volume purchasing power of a single-payer system would reduce drug prices. Mrs. A would be able to take her Arimidex every day as prescribed, instead of scrimping and jeopardizing effectiveness. Mrs. Z would no longer have to rely on a Canadian pharmacy. 2, intravenous chemotherapy that could be given through the office would be available to all. Mrs. B could get her therapy using a portable infusion pump at less cost to the system without paying the personal penalty of intermittent hospitalization. 3, health coverage would not be optional. Mr. X would not be faced with the agonizing choice of health insurance premiums versus solvency. The financial disincentives to obtaining life-saving screening procedures like mammography and colonoscopy would disappear. Participation in these measures would increase, and mortality from breast cancer and colon cancer would decline even further. 4, health care coverage would be free from its connection to employment. Losing one's job would no longer entail the risk of losing one's life. Mr. Y could get timely evaluation for a bone marrow transplant without giving his cancer a head start. 5, marginally effective but outrageously expensive cancer treatments would not be available. Effective central planning, feasible only under single payer, would require the establishment of an American equivalent of Britain's National Institute for Health and Clinical Excellence, known by the somewhat ironic acronym of NICE, charged with assessing the value, not just the effectiveness, of new drugs, procedures, and devices. If a drug offers not cure but only a few weeks to a cancer patient's life expectancy and is prohibitively costly, society would not be harmed by its exclusion. And 6, our office operation would be more efficient and less costly. Our billing clerks tell me that if all patients had Medicare, their work would be reduced by at least half. My 2 partners and I, 3 doctors, have 25 employees, of whom I count at least 4 who would be unnecessary under a single-payer system. Now, my experience and that of my patients are not unique. A recent report by the Kaiser Family Foundation and the American Cancer Society confirmed that the present system is hazardous to cancer patients nationwide for reasons not limited to those just outlined. Medical oncology thrives on new drugs. They are one reason it's such an attractive specialty. Even more important to me, the new drug development, however, is the prospect of being able to apply what we now have to all Americans without the deterrence of unemployment, poverty, or age. Medical oncology as a specialty is young enough, and I'm old enough, that I was able to get in on the ground floor of what was to become an exciting, vibrant medical discipline. I fervently hope that before I retire, I can experience the satisfaction of seeing all my patients benefit fully from the successes of the past 4 decades, not just the prosperous and the lucky. Thank you.